advanced. Thank you.
Thank you, Dr. Philippe. We'll shift it to the next. For pattern of local recurrence post-radiotherapy, Ain Shams breast cancer units experience. My dear Professor, Dr. Muhammad Sabri.
Thank you, dear colleagues. Thank you, Chairperson. I want to highlight this very simple, interesting case presented to us last year in the COVID era. Unfortunately, we're still in this era. But to highlight the selection of patients during COVID era is strictly using IMRT for highly selective cases because time of exposure to radiation. So we started this case to delineate it in the COVID era. She's right breast cancer. You know that's IMRT technique or any advanced technique for radiotherapy of the breast is selected usually to the left breast because of lead and coronary blood vessels, and right breast cancer receiving 3D conformed radiotherapy. This case presented 1 year ago, 55 years old female presented in the breast cancer unit to start adjuvant treatment and post-operative radiotherapy, T2N2, 5/11, lymph nodes positive, multicenteric disease. She did a lumpectomy, and she started adjuvant chemotherapy, 5-AC, followed by 12-week Taxol. The patient started adjuvant post-operative radiotherapy to the chest wall and peripheral lymphatics, 40 gray over 15 fractions by three-dimensional conformal radiotherapy. The matching between supraclav and tangential phase was by half-beam block technique, and the tangents was matched with couch rotations. The patient finished radiotherapy course without acute toxicities. She started adjuvant hormonal treatment, letrozole, every day. 1 month later, she started to complain from right hypochondrial pain. Laboratory investigation shows elevated transaminases up to 5 folds. Abdominal ultrasound and CT scan with contrast shows no radiological abnormalities except all standing mild liver cirrhosis with minimal ascites. We did all of investigations to exclude this is a malignant recurrence. After 1 month, the liver support given by hepatology consultation, the liver transaminases became normal again, and the patient classified by child B6 chronic liver cirrhosis. 1 year later, on regular follow-up, the patient presented with abnormal ultrasound finding. We found that the patient has heterogeneous hepatic parenchyma. She consulted the hepatology, said that it may be from old standing cirrhosis, but he required to do a CT scan to define this heterogeneity. The CT scan shows abnormal straight fibrotic bands affecting the hepatic dome. You can see this straight band in the hepatic dome are quite strange, not matching with the usual chronic cirrhosis we found in our patients. We revised our delineation. We found that the same angle of this band are matching with the same angle of tangents, and also required CT scan and approved that is a post-radiotherapy effect of the liver. We revised our planning and our field dimensions and V30 for the liver. We found the patient has a special anatomy of high copula of the frame, which is uncommon features with those obese and short status patients. The tangents plan is covering actually the field of chest wall and did not extend it more than usual in the lower border. Although the caudally diverted lower edge tangents beam after couch rotation increases the hepatic volume irradiated through the radiotherapy course. We found that there is a case report, many case reports published worldwide about this rare presentation of toxicity. Radiation-induced liver toxicity are divided by 66% patients exposed to an 30 to 35 GY of radiation. I know that Dr. Yusri have a heavy experience about hepatic radiation, and many of our patients have a chronic liver disease, and V30 of even the whole volume of radiation of the liver depends upon the reserve of healthy hepatic tissue reserved in our patients. So the patient may present in this case, or actually presented by ascites and hepatomegaly and elevated liver enzymes, is triad caused by the hepatic radiation in many patients. Take home message that radiation-induced liver disease is not uncommon scenario, especially for the patients with, and should be included in organ at risk, especially for the patient with high copula and special anatomy of obese and short stature. Yeah, we found that many of these patients have high copula of the frame, and the liver should be included in the organ at risk. Matching of tangential fields with supraclav fields, but gout rotation is not preferred an option for those patients. Thank you.